Good morning, everyone, and welcome to this session of the short oral presentations. My name is Irene On, and I'm a pharmacist and lecturer here at the School of Pharmacy at the University of Sydney. I'd like to first open this session by acknowledging the traditional owners of Australia. We're currently on the land of the Gadigal people of the Eora Nation. I'd also like to pay my respects to elders past, present, and emerging, as well as acknowledge any Aboriginal people in this room today. So we have 4 presentations for this session. Unfortunately, Professor Tim Chen had to step out, but hopefully he'll be joining us. You may have seen that his name is also mentioned on the program. And if you were referring to a previous version of the program, unfortunately, one of our presenters wasn't able to make it. So we'll only be having 4 sessions right now. So for the presenters today, we have 5 minutes for the presentation and then 5 minutes of question time. So I'd like to ask our delegates to listen attentively and also participate in the discussion afterwards. So I'd like to first welcome Joy to the stage. So Associate Professor Joyce Spark is a registered pharmacist and pharmacy program lead at the University of New England in Australia. Her research interests include facilitation of student learning, equitable assessment, work-life balance, and user perceptions of services, whether they be in health or education. Working with Rasch analysis has enabled Joy to gain a greater appreciation of the complexities of scale development and validation. So could you please all welcome Joy?
Professional identity, what is it and how do we measure it? One definition of professional identity is the values, attitudes, knowledge, beliefs and skills that are shared with others within a professional group. There have been several studies of pharmacists' perception of their professional identity, and a scoping review found that it was multifaceted, and they put things into 5 groups of clinician, dispenser, business person, patient counsellor, and physician. One of the scales that can be used to measure professional identity, particularly, and has been used a lot in health professional students, is the McLeod-Clark Professional Identity Scale. We used that with specific modification to mention the pharmacy profession, a 7-point Likert scale from strongly disagree to strongly agree. And there are 3 items that need to be reversed when they're scored because they actually are negatively worded. A recent systematic review found that this particular scale was, while it was one of the better ones, there wasn't adequate psychometric testing of it. So we chose to examine the construct validity of this scale using Rasch analysis. We did this through a cross-sectional survey of pharmacy students who are aged between 18 and 61 years. We have a lot of mature age students, and predominantly female, about 2/3 currently working in pharmacy. When you look at the actual responses across the scale, one of the things is the fact that it's skewed. The grey lines are the midpoint, and you can see that there's very few items below the midpoint, responses below the midpoint for the positively worded questions and above the midpoint for the negatively worded questions. So showing quite a lot of skew. So when you put things into the rush analysis program, one of the things that modern test theory does is look at whether the responses are happening in an ordered manner. And that wasn't the case with the 7-point scale, and I couldn't recode them so to the point that it would ever become ordered. And so sometimes when people use a Likert scale or respond to a Likert scale with a midpoint, the midpoint's used for the, I don't know how to think about this, I'm just going to dump it. And that's what's happened with this scale. So it doesn't actually act for some of the questions. For some of the questions it didn't, but for a number of the questions it did. So we had to remove the midpoint. We chose to remove the midpoint response for all the questions rather than leave it in. And when we did that, we still had some of these questions that were coming up as what I call disordered, or what are known as disordered. So I thought I'd talk just a little bit about what that meant. So this is an ordered question where the response categories are going across along. Responses on the left are people who have a low score on the scale that we're measuring, in this case, professional identity. Responses on the right have a high score on professional identity, and responses move across that, and each response has a spot along the category that isn't hidden by the other responses. When we're looking at a disordered question, in this case, it was one of the negative questions, so the scoring is the reverse because the high scores are the low ones on the scale. You can see that 2 of the peaks are hidden. They haven't appeared above the other peaks. And so you have to and the way to manage that is to rescore. So change this to work out how to score. Now, if you've got disagree and agree items, you can't merge them together. So you keep the disagree on one side and the agree on the other. And in this case, because of the way the responses came out, we coded the 2 middle disagree and the 2 middle agree ones together, and that provided us with an ordered response. So we can see now that the peaks are coming out nicely. With the case of the positively worded questions, because there were so few disagree elements, it's actually the disagree items that are hard, just don't appear at all because there are no responses. So we recoded all the positively worded questions as 0, 0, 0. So all the disagree items were as 1 point, and then the ones above it as separate points. And when we did that, lo and behold, we actually managed to get ordered. Doesn't always work as cleanly as that one did, but in this case, it did. Then one of the other things that can impact on scales is what's called response dependence, i.e. there's a couple of items or 2 or 3 items in the scale that actually are closely related to each other, and they can artificially inflate results. And we found that there were an interrelationship between all the reversed questions, all the negatively worded questions seem to be very strongly correlated. And the way that the scale worked best was to remove 2 of those. And so we removed both question 3 and question 4 were removed, and that left us just with question 5, one reversed question. When then looking at whether it's still unidimensional or multidimensional, and in this case, we didn't have enough data because we'd removed the midpoint, which means there's a lot of missing data. So we we couldn't use the more substantive test, but the less substantive test showed that there was unidimensionality, which is also important when you're looking at scales, because you want to make sure that you're only looking at one major construct. Within Rush analysis, there's a thing called person separation index, which sort of replaces Comprux alpha, and has the same sort of measurement for those who are aware of the alpha internal consistency scale. And so this is about 0.74, which is quite good. And all the other statistics were showing good fit to the model. When the program they use has the ability to look at the spread of the responses versus the spread of the item difficulty, and these are reasonably well matched with one exception, and that's a question that no one gave a negative answer to. So that's very low down there, but otherwise they're fairly well matched. We also had the ability to look at some of the demographic differences in response and found that there was no difference in response on gender or year level, which is probably not what was, but the main difference for our cohort was experience working in pharmacy. And with 65% of the people working in pharmacy, it's probably no surprise that the people who work in pharmacy had a higher professional identity or association with the pharmacy profession than those that didn't. So in conclusion, there was a high response dependence within the negatively worded questions that artificially inflated the Comprux alpha received in previous development. And we suggest moving forward that the item scale be used with an even number of response categories, and in consideration to actually collapsing the disagree items for the positively worded questions into a single item. So you end up with 4, but not, but starting out with a 6, because you need to spread out the positively worded questions. Thank you.
So do we have any questions for Joy?
Great presentation. I know you looked at, I know you were measuring all of these outcomes, but I was curious to know why someone would be ashamed to say that they don't study pharmacy or want to be associated with it.
Well, that would be a qualitative research question rather than these questions were put together by the people who designed the scale, and they were looking at trying to find questions that would help identify whether someone had a positive affiliation with their profession of study than not. And so if they're not really associated with it, or they don't have a very high opinion of it, then they're going to feel ashamed that that's what it is. And so it's going to be perhaps unlikely, but some people do for whatever reason, and depends on your experience.
Thank you so much. So usually we use Likert scale, right, to ask a range of opinion. When we should use RAS scale instead of Likert scale? Thank you.
This is did start out as a did start out as a Likert scale, in that we've got the strongly disagree across the item. So it is actually asked as a Likert scale, but the RAS analysis enables you to see whether the actual responses have been ordered across the domain that you're actually measuring. And that's something that you don't get by just looking at the responses, because although I guess you can look at it and say, there's a problem with the disagrees because hardly anyone's got there. So what do I need to collapse categories or not? But you can't really tell whether they're how to rescore. And that's one of the things that sort of distribution, it's a probability based rather than the classical test theory that's a different base.
Thank you, Joy. The call, please thank Joy. So I'd like to invite our second speaker, Shania Liu, who is a PhD candidate from the University of Sydney School of Pharmacy, working on interventions to improve the safe use of opioids among patients receiving hip and knee arthroplasty.
Hi everyone. Before I start, I'd like to acknowledge funding received from the AVOT Foundation and NHMRC, which had no role in the design or conduct of this study. So opioids are commonly prescribed for chronic osteoarthritis pain before orthopedic surgery, despite limited evidence to show that they're any more effective than non-opioid analgesics. This is a problem because we know that pre-operative opioid use is associated with worse post-operative pain, surgical outcomes, and longer length of hospital stay, leading to higher healthcare costs. We also know that pre-operative opioid use is linked with persistent opioid use after surgery, which is associated with further harms, including opioid tolerance and dependence. The Australian Atlas of Healthcare Variation highlighted significant differences in rates of overall opioid use between metropolitan, regional, and rural areas, as shown by the colour differences in this figure. However, it's unclear whether these trends extend to preoperative opioid use as well. Therefore, we conducted a study to examine the prevalence of opioid use before elective orthopaedic surgery across Australian metropolitan, regional, and rural areas. Our secondary aim was to examine the association between hospital setting and preoperative opioid use while adjusting for covariates. So to do this, we conducted a multi-centre cross-sectional study between April 2017 and November 2019 across 5 hospital sites in New South Wales listed here. We included adults undergoing elective orthopaedic surgery and excluded those who were receiving procedures for malignancy or those unable to complete the study questionnaire due to a medical condition or language barrier. We recruited participants from hospital pre-admission clinic visits, which were held 2 to 6 weeks before surgery. So we collected data including analgesic use and opioid use before surgery and differentiated daily versus any opioid use. Daily opioid use is fairly self-explanatory, and we defined any opioid use as the use of an opioid analgesic at any point in time over the previous 14 days. We collected degree of residential remoteness and socioeconomic decile using national classification tools developed by the Australian Bureau of Statistics. And indicators of depression and anxiety traits were collected using these tools listed here. So this table summarizes our findings from the 430 patients included in the study. And we can see down the bottom that the prevalence of any opioid use before surgery was 37.7% in this cohort, and daily opioid use was reported by 25% of participants. We used multivariable logistic regression to show that participants undergoing elective orthopaedic surgery at an inner regional hospital were more likely to use opioids before surgery compared to those attending a metropolitan hospital. Down the bottom, we've got the covariates of preoperative opioid use, which included female gender, a history of chronic pain, depression traits, and tobacco use. So our findings appear to be consistent with existing literature, with previous rates of opioid use before surgery reported between 15.7 and 54%. Our study was the first to identify the regional setting as a significant predictor for preoperative opioid use, which supports data from the Australian Atlas of Healthcare Variation. Potential reasons for this include inadequate access to health services and the greater prevalence of chronic pain, depression, and tobacco use among these populations. So a strength of the study was the inclusion of multiple sites, which improves the generalizability of our findings. However, there are limitations which we need to acknowledge as well, which include the use of patient self-reported data, which carries risks of response and recall bias, and other factors affecting preoperative opioid use, including local prescribing practices, unfortunately couldn't be collected. So in summary, nearly 2 in every 5 patients were using opioids to some degree before elective orthopaedic surgery. Given the significant variation identified in rates of preoperative opioid use between metropolitan and regional or rural settings, future studies addressing this should consider targeted strategies based on the local context. And finally, I'd like to thank the team who made this project possible, and thank you very much for your time. Happy to take questions.
So any questions for Shania?
Thank you for an interesting presentation. I possibly missed it, but what sort of analysis did you do to look at the associations? Was it multi or single?
So we did, was it just with regards to the association between preoperative opioid use and, yeah. So we did multivariable logistic regression. So we accounted for potential covariates, which may have also contributed towards preoperative opioid use. But in particular, we were interested in seeing whether or not the location where patients were residing and received their surgery also impacted preoperative opioid use.
questions from the room?
Yeah, that was really interesting. Thank you. I was just interested, the rural hospital, was that like a hub for other towns? So was it the person's residential address that you were looking at, or was it the hospital that they attended?
So for the regression analysis, we only looked at the hospital where they attended, but the individual hospitals were served as catchment areas for patients in that local area. So that was the reason that we used the hospital area rather than residential address for the multivariable logistic regression.
Shana, I have a question. You mentioned the differences between the metropolitan versus, I suppose, the regional areas, and potentially due to reduced access to services. So maybe you could just describe some of what we have in metropolitan areas that would, I suppose, show us these numbers that you presented to us.
Yeah, of course. So in terms of the metropolitan areas, some of the services that we have available to help patients who have moderate to severe osteoarthritis pain before the orthopedic surgery include multidisciplinary chronic pain services. But unfortunately, we know that the wait time to these services is even longer in patients who reside in regional or rural areas. So access to these services is a bit of a challenge in some of these areas, which might contribute towards a greater reliance on opioids to help with pain before surgery.
Okay, so is there other questions? Could we please thank Shania? So I'd like to invite Linda, our next presenter. So Linda Doe is an academic tutor undertaking a Masters of Philosophy at the School of Pharmacy at the University of Sydney. She is also a practicing pharmacist at the Canterbury and Liverpool hospitals and holds the position of Secretary on the Society of Hospital Pharmacists Australia, New South Wales Branch Committee. Her passion for professional training and development of pharmacy students has led to her research to focus on student-led, entrustable professional activities pertaining to a clinical practice experience. So if we could please welcome Linda.
Thank you, Irene, for the introduction, and hello everyone, I'm Linda. So today I'm just going to present to you my evaluation of the Student MedRec program that I've been had the pleasure to coordinate over the past couple of years. So just a bit of, I guess, background to the program is that medication history taking at its core is an entrustable professional activity. Basically, we train students at the university, then send them out to the hospitals and let them go and take medication histories. We either with minimal to very minimal supervision by the pharmacy teams, just empower them to integrate into our workflow, and enabling that does part of the Miller's Triangle or pyramid. And as part one of my qualitative research is to evaluate student-led MedRec in hospitals from the perspectives of stakeholders, students, as well as their pharmacist preceptors. So this is a progress to date, but just to cut out the COVID bit, just because I'm sure you guys have heard a lot about COVID so far, and I'll just concentrate on the data that I've collected over 2019. So with the stats, we've covered 5 hospital sites, sent out 70 students, meaning 35 pairs of students. They've taken a total of about 1,400 histories, averaging to about 8 per day, and that's across a 10-week period for that year. So in terms of qualitative research that year, 70 students were recruited, volunteer basis. I've had the consent to review up to 49 student reflections, as well as being able to conduct focus groups and interviews with up to 32 students, as well as 23 preceptors. And everyone was all data was de-identified, thematically analyzed, and quotes and themes to come. And I guess I noted down to 3 main themes amongst the students as well as the pharmacists' point of views. The first one being student preparedness. How did the students feel about how they felt? And I guess just generally speaking, just to cut to the chase with the quotes in light of time, is that I guess that students did feel that they did feel prepared, maybe even over prepared in some senses, as we are a bit pedantic on the hospital level when it comes to orientations. We love to immerse them in, I guess, electronic medication records and know how to play around the computers and navigate the resources there in order to help them take a medication history. But students definitely felt once they're in the wards, they're actually practically hands-on with the training. That's when they actually learn the fastest and learn the best. And in order to continue enabling that skill to take medication histories. From a pharmacist point of view, they felt that students definitely were well structured based on the university program. They felt that reassurance that students are able to come on board well prepared, and it's just about the local nitty-gritty of work health safety and where everything is in the hospital. And I guess further to that is that I guess pharmacists were very keen to have students on board, to have them under the wings and help them out with medication history taking, which can be very time consuming, as we can understand. The second thing that I want to cover was real life complexity. So what does that really mean is obviously when we prepare students in a simulated classroom environment, is a safe environment, not as realistic as we'd like it to be. And we can only simulate or role play the best as we can here in the university. But once we send the students out to hospital, they're going to encounter patients who are quite complex, patients who can't really speak as well, whether it be language barrier or just have cognitive impairments or so forth. But one other things could be quite shocking to the students as well that they would never have thought would encounter would be things like, just juggling the time with patients going to x-rays and not being available there, waiting for them to take a history. They have to wait and coordinate that sort of schedule, as well as perhaps needing to reach out to family members or carers. And that could be a very difficult conversation when their family members in the hospital is quite unwell. So they need to learn that bit of sensitivity or empathy on that level of scale. Pharmacists felt that, I guess, generally speaking, it's just about the practicalities on the ground. So let's say ED is a very busy place. We had students in one site taking medication histories in ED. It's very fast paced. Patients will move around very quickly. And by the time students will be quite thorough with their histories, it will take a bit of time. And by the time the students are done or nearly done with the histories, the patients would have moved on, whether discharged or moved on to another ward. But look, if they are in the ward or still in the hospital, that information can be transferred, but there has been some internal, I suppose, problems and challenges with communication there. And again, echoing the idea of language barriers as well. And I guess just as a final theme from a pharmacist's point of view is that I guess their workloads are always generally overwhelmed, and obviously this onboarding of a new type of program, they basically felt like there's a lot to juggle, and one pharmacist definitely reflected on the fact that they pulled at almost 5 different angles. And as much as these guys love to take on students to have them under their wing, they wanted to spend more time with the students and actually really train them up and enable them to do more histories. And in terms of 2019 was an ideal year where we had 10 weeks for students to go out to, but I know in other years, just as a bit of a brief, is that students were not there for long enough. So it's just something to reflect on. And in terms of significance of this moving forward, we do want to continue this MedRec program. As you can see, it has been continuing and will be continuing this year, which is really exciting. We need to refine the program if we want everything to be met adequately, whether it be student supervision, training, or preceptors' expectations of workload and all that. And it's a discussion amongst, at the end of the day, preceptors and students to make sure that all requirements are met on the ground. And I would just like to acknowledge my supervisors, the hospitals, as well as the students who have come to date, and some of you guys in the crowd probably can find your peers on the photos. And I thank you.
So any questions from the room?
Linda, congratulations. That's a great, great piece of work. I wonder whether you could comment a little bit further on the students doing the MedRec and that is to be taking when they identified a clinically significant medication safety issue. What were the processes there to integrate this into their placement?
Yeah, thank you, Tim, for that. And yes, escalation protocol is definitely a big thing. It's a big thing in the hospitals. Obviously, once a student finds a problem, let's say double anticoagulants or something very accidental like that, it is a big problem and we need to escalate it straight away. So I guess over the years, there's been many like discrepancies that students can pick up, and we've managed to identify that students can identify discrepancies, whether minor or major. And we kind of split it off into that. And minor could be like vitamins being left off or something very minor like that, to double anticoagulants being a bit more major. And so major ones, escalate straight to the pharmacist as soon as you can, or speak to someone straight away to get things fixed. Minor ones, it can probably wait until maybe at the next meeting with the pharmacist when they're actually available and at the scheduled meeting time. So hopefully that answers.
Great presentation, Linda. I was just wondering, on the second slide with the quotes,
Yeah.
you said there were sometimes pharmacists found that students were missing some details. And I was just wondering what kind of details they would often be missing.
Yeah, so thanks for me for that. So yeah, so in terms of nitty-gritty details, I would say on further, before all those quotes, pharmacists did say students were helpful, they were able to take basically a pretty solid history. But when it comes down to the attention to detail and the experience that they're kind of missing, that is what they're kind of missing. So let's say, for example, forgetting to ask eye drops, ear drops, patches, creams, and all that stuff, the nitty-gritty stuff. Sometimes they might forget it, or sometimes they might not word it in a way that's intuitive for a patient to understand and therefore claim. So we know that one thing is about asking the question, but asking it the right way for the patient to actually respond appropriately. So those were the nitty-gritty things. And I think further to that is, I guess the reflection is pharmacists do feel students should go back to these patients to clarify, and that was strongly encouraged as part of the training. Thank you.
So Linda, I have a question. So it seems like the students had a really good opportunity to actually reflect on their experience by doing interviews with you. Could you just comment maybe on I suppose what the students are currently doing post this activity in terms of reflection, or what else happens, I suppose, after this experience?
So in terms of post-reflection, I guess after the program, students were able to reflect through their placement assignments. Is probably a requirement for their study, but I guess in the focus groups, they were just able to just sit down and just reflect on, I suppose, what is it for their future practice. And I think something that I haven't really mentioned or been able to mention in the slides is probably the fact that I suppose students were able to sit down, reflect and think, okay, maybe hospital is for me or hospital isn't for me, or the skills involved and how busy the environment could be. And they really figure out where they want to be in the future, or in the immediate future, at least, from internship to early career pharmacist, and maybe thinking maybe hospital pharmacy is or isn't their path moving forward. And there's different skills and knowledge involved. So they're prepared. They know that what are the gaps they need to fill, and perhaps anything else that needs before they enter that hospital environment. I hope that answers your question.
If there's no other questions, We could all please thank Linda.
Thank you.
I'd like to just invite up our last presenter, Clara Strobel, who is a recent graduate of the Master of Global Health and started her MPhil at the University of Sydney in 2021. She is conducting research around perinatal mental health. Currently, she is exploring pharmacist perspectives on community pharmacist-led perinatal depression screening. So welcome, thank you.
Thank you for the introduction. So today I'm going to present the research I worked on with Dr. Elden and Professor Ryan Greenwood on pharmacist acceptability of perinatal depression screening in community pharmacies. So perinatal depression refers to depression that occurs during pregnancy and until 1 year after giving birth. And globally, according to a review, antenatal depression prevalence ranges between 15 and 65%, and postpartum depression prevalence is approximately at 17% on a global scale. So screening is an important method to identify women with perinatal depression, and a study in 2020, for instance, showed that 1 in 5 Australian women did not receive the adequate amount of screening. Overall screening can be conducted by primary health care professionals such as pharmacies, and that's why we the research aimed to investigate the pharmacist acceptability of pharmacist-led perinatal depression screening, as well as look into the training and resources that would be required for such intervention. So now moving on to our methods. So a questionnaire was distributed to Australian pharmacists by email and other social media platforms. And this questionnaire entailed 3 open-ended questions that aim to understand pharmacists' perspective on their potential role in perinatal depression screening, as well as the training and resources that will be required. And due to the richness of the responses, we decided to analyze these via content analysis, meaning that we first familiarize ourselves with the data, then developed codes that captured the key ideas of the responses, and then these codes were then eventually clustered into groups from which categories emerged. And categories that emerged from question 1 on pharmacist role were then also mapped to the acceptability framework, which consisted of 7 constructs that are listed on the slide. So a total of 149 pharmacists participated in the study, which were between 21 and 66 years of age, and the majority were female. So this leads us to our results on the pharmacist role in perinatal depression screening. Due to time, I'm not going into too much detail. However, 4 major categories emerged, including benefits of perinatal depression screening. And so codes such as convenient, less intimidating, a valuable service were important discussion points that were identified in the data. And for instance, participants said it can help women who would otherwise fall through the cracks. Then another important category was system and policy changes, in which participants discussed different issues, for instance, time constraint, needing remuneration, and also as discussed in the quote, there was a discussion around needing to hire more staff to be able to perform the screening. And all these were then mapped in line to the acceptability framework. So now moving on to a brief summary of the results on training and resources. So regarding training, 3 major categories emerged, including training content. And the participant discussed about ideas what training should entail. And there was a lot of discussion around around implementing communication training and how to approach the patient, as stated in the first quote. Then regarding to the resources, 5 major categories emerged, including training materials for pharmacists, and our participants, for instance, said that screening sheets and interpretation forms would be required. So in conclusion, the majority of the pharmacists were interested in pharmacy-led perinatal depression screening and also felt could be part of their role as a pharmacist. However, the acceptability was dependent on whether training and resources could be supplied, and as well as the overall support of the broader health system. One limitation was volunteer bias, since it was a self-selected voluntary participation in which they could take part in the survey or not. And then future direction, so our findings could be a potential guide for developing perinatal depression training to support the community pharmacists and to expand their role in screening. And so now I want to thank my advisors, the entire research team, as well as the Lifespan Grants Program for making this research possible. Thank you for listening.
Thank you. Is there any questions from the room?
Thank you very much for a very nice presentation. You presented the open-ended data from the survey and mapped all of the themes or all of the data to the acceptability framework, which is excellent. Can you tell us a little bit more about the quantitative data from the survey?
So this study is part of like a big survey, and there was so one part. So it had 3 sections, and I focused on the last section, which was only the qualitative part, which entails, like you said, the 3 ended open questions. And the first and second part was, like you said, the quantitative part with the demographics, and then there were questions about like strongly agree, do strongly disagree on some questions. However, I was not responsible for the first and second part of the survey. Yeah.
We have an opportunity for a few more questions or comments from the floor. Thanks, Becky.
Thanks, it was an excellent presentation. I know there were a couple of barriers that you put up as far as quotes, you know, so a bit more, we need more resources, more staff, etc. There's certainly around the benefits and the accessibility. Obviously, they're very positive quotes. Did you actually have any negative? I'm just interested, was anyone going, this is not our role, you know, pharmacists should just keep their nose out of this? Like, I'm just curious, was there anything that's like totally different to this positive?
Absolutely. So basically the majority were very positive about it. And there were a few, but very few, like I would say maybe 8 of the 149 participants were against it. Whereas like the other ones were all positive, they really wanted to be part of it. However, there were always like one requirement would be, for instance, resources or training, etc.
Yeah.
But overall, it was very positive.
Okay, thank you.
Okay.
What were the negative things? From the 8?
The 8, yeah. The negative thing were really about it's not our role, it's not part of the scope of pharmacies, and about a lot about time constraint and like heavy workload, etc.
Any other questions or comments from the floor? If not, please. Oh, sorry. Yeah.
You had a great presentation in a really important area, and I'm sorry if I missed it. Is there any difference in sort of
I guess, acceptance or benefits according to differences where people worked or their experience in pharmacy?
So basically a big difference, I would say, is between rural and urban pharmacists. In rural, they were really positive about it due to the fact that there's not many health services around. So that was the biggest difference, yeah.
If not, please thank Clara for and an excellent session this morning, this afternoon. We now have lunch served in the common room. So please enjoy your lunch and